All right, we are we are live on YouTube. We'll just wait a couple minutes to begin.
Okay. Good evening, everyone. I hope everyone can hear us. Welcome to the second of 3 of these virtual town hall meetings by the Mayor's Commission for Racial Justice and Equality. My name is Renee Shaw. I'm the managing editor, producer, and host of KET's Kentucky Educational Television's public affairs programs. I'm glad to be the moderator for these events tonight. Last Tuesday, the other day, you can go back online and watch those as well. And we have another coming up on next Tuesday. Tonight, our focus is on health disparities. We had a very vigorous conversation on Tuesday about racial equity in education and economics and economic stability and empowerment. And then next week, there's a series of issues that we will tackle. But tonight, we're focused on health disparities. We have an august body of panelists, some very distinguished panelists who are with us today who are experts in this field of healthcare and who know a lot about what sometimes you'll hear the social determinants of health, where you live, where you work, how big your bank account is, and determining your quality of life and health outcomes. And so we're going to get right to it. But first, we're going to invite our co-chairs of the Mayor's Commission to give us some opening remarks before we talk in depth about the issues confronting Lexington, Fayette County when it comes to health outcomes. I'm going to turn it over now to Dr. Gerald Smith, who is the Commission's co-chair, after which you'll hear from Rosalind Akins, also the co-chair of the Commission. Gerald.
Thank you, Ms. Shaw, and thank you for once again hosting the second of our town hall meetings. I'd like to begin by welcoming everyone, especially our vice chairs and other panelists who are joining us this evening. Again, this is a second of 3 town hall meetings where we're seeking to ascertain as much information as possible from the community regarding their perceptions and perspectives tonight regarding health care and health issues in Lexington and Fayette County. So I'm going to turn it over to Ms. Akins, and she'll share with you the purpose and guiding principles.
Thank you, Renee and Dr. Smith. The purpose of the Mayor's Commission on Race and Equity is to assemble diverse community members to listen, discuss, and create empowering solutions that dismantle systemic racism in Fayette County. And so all of our subcommittees have 4 guiding principles. They are acknowledgement, ask, address, and then there will be action. And so tonight, Renee, we turn it back over to you as we talk about health disparities here in Lexington, Fayette County.
Thank you, Roz, and thank you, Dr. Smith. And we do want to invite you to submit your questions and comments tonight so that those can be vetted by this committee. Many of you participated the other night, and we want to see that same kind of robust engagement tonight. You can email your questions, and I'll try to remember to repeat this throughout our hour and a half together. email your questions to townhall@lexingtonky.gov. That's townhall altogether at lexingtonky.gov. And those questions will be passed along, and we'll get to many as time allows. Before we get to the questions and talk about those issues in depth, I would like to read a statement that Mayor Gordon sent today that she wanted to have read at the beginning, and perhaps we can reiterate it at the end, thanking all of the members for their participation. And it reads, and I'll read as she sent it. This is Linda Gordon, and I want to thank members of this commission for all of your dedication to the work at hand. This is not easy work. I have been watching the subcommittee meetings as well as the previous town hall meeting, and will watch tonight's. I understand the difficulty and challenges of what you are committed to doing. Thank you to members of the public who are watching and participating. This is our opportunity to make meaningful change for Lexington and all of our people who live here. We must take it now. And she thanks me for serving the community too. And thank you, Mayor Gordon. She ends with the salutation, stay strong, everybody. And many thanks, Linda. So Mayor Gordon, thank you for your leadership in developing this commission and having such fine folks to helm it in so many ways. And tonight's vice chairs, I want to introduce all of the folks who you see on your screen tonight. Dr. Takia Talbert. She is a vice chair of the Health Disparities Committee. She's executive director of diversity and inclusion at UK Healthcare. Dr. Lavoria Williams. She's also a vice chair of the Health Disparities Subcommittee. She's an associate professor at the UK College of Nursing. Michael Halligan, executive director of God's Pantry Food Bank. Vivian Lasley Bibbs, acting director, Kentucky Department of Public Health, Office of Health Equity, and vice chair, Foundation for a Healthy Kentucky. And last but not least, Casey Allen Bryant, lecturer, UK College of Nursing, and immediate past president of Lexington Fayette County Board of Health. So thank you all for your participation and commitment to health disparities. And perhaps I want to start with you, Vivian, because I've had you on many of my shows, as I have almost everybody pictured here. But we've talked a lot about social determinants of health, which sounds like a pretty good sizable lexicon, but it really translates to health disparities. And if you would just kind of define for us what that means, what it is, why it matters, and why it matters that it be addressed.
Well, you know, for so long, we've tried to address health issues with that individual one-on-one, trying to address the health behavior. But as we've kind of had our aha moment in population health, we've really looked at what's happening with folks' physical and built environment, their housing, transportation, quality of schools, education. All of that impacts health, not just that physical, what you walk into the doctor's office with. And I think we're learning that both in public health and in the healthcare professions, that we need to start thinking about those social determinants. Just like you said earlier, where you live, where you learn, where you work, where you play, and even we're finding out where you pray. So there's a lot of things to take into consideration and how they all impact health and health outcomes. And I think we can't forget that. And I think that's going to be critical as each of these groups move forward, because they're all interconnected. We're all this intersectionality among them all. And I think we need to remember that moving forward when we talk about health and healthcare access and what that means for our Black and Brown communities in the city.
Dr. Talbert, so it's not just a matter of lifestyle choices, correct? Sometimes we think that the main determinant of someone's health and their health outcome is how they choose to eat and exercise or not exercise, right? But this is much broader than just lifestyle choices, correct?
Absolutely, absolutely. And just as Vivian stated, it's all those things combined that put people structurally and socially disadvantaged, right? And these populations have a harder time with access to healthcare and healthcare in and of itself, and reaching their full health potential. And so I think it's always been perhaps easy. I'm going to say that. Yes, I am. I'm going to step out and say it, that it's always easy to maybe blame the patient or the consumer when technically we have some structurally systemic racial issues within our healthcare system that need to be addressed, and definitely taking a broader look and scope at the patient and where they live, sleep, eat, and pray, and play, and grow. So,
right.
Absolutely.
Yeah,
Absolutely.
Dr. Williams, same kind of question to you. Taking it a little step further, we know about food deserts, right? And this is one place that I hope that this subcommittee is really going to address, that there are places and we know that they don't have easy access to healthy foods, that the
Absolutely.
best choice is not the easy choice, right? The best
Absolutely.
choice isn't the most accessible choice when it comes to making lifestyle or even having accessible sidewalks so that you can walk and
Yes.
in a place that you can play that's free of crime. So if you can just
Mhm.
talk about those things beyond, that are the food deserts and other things that play into this.
Absolutely. Often it's been said that when the patients come to see us, that the advice that we give, they've heard it before. They've
Mhm.
heard that they should change their diet, they should exercise 30 minutes 5 times a week. Um, but we don't pause enough to ask, what are the barriers, the challenges that they're facing so that they're unable to do those things? Even healthy foods, when we tell people, well, you should have 5 fruits and vegetables each day. If their closest supermarket is not a supermarket, it may be 5, 10 miles away, but the closest store is a neighborhood market that does have fruits and some vegetables, but it's not suitable for them to
Mhm.
eat oftentimes.
And
And
what do you mean by that? Just to clarify, what do you mean by something?
well, sometimes there's a very limited amount, and more often, the fruit and vegetables are older, not as fresh, and, and therefore not as healthy as one would like to
Mhm.
have.
Right. So Casey Allen Bryant, what is it that you hope this subcommittee in particular will accomplish? What are you looking at in all your years of healthcare? This is what we really need to hone in on and chip away at when it comes to these health disparities.
Right. So I've been a public health nurse now for 20 years, and I've been a public health nurse here in Lexington, Fayette County. And so I feel like I do know this area and this population very well. And so some of the goals that I have for this committee, obviously, we just don't. Okay, decreasing health disparities, that's a duh, right? But I also want to increase that access. I want to increase the relationships between our healthcare community and our Black and Brown communities. I want to increase resources for our Black and Brown communities. I mean, I really do want to see, other than just reducing those numbers. I mean, yes, we know we want to reduce the numbers of diabetes. Yes, that's great. But there's also other things that we need to change, other societal policy level items that we need to change to really help our Black and Brown communities. And that's what I would like to see.
Can you name
Absolutely.
one specific policy item that you would like to see changed?
Well, just what Dr. Williams was talking about. I wasn't on this meeting, but our last week's meeting about the food deserts of mandating having grocery stores with actual fresh produce in them available to our Black and Brown communities, having safe parks and recreation available for our Black and Brown communities so that they can exercise, having it mandated that healthcare facilities have to have those off-hour outreaches so that our Black and Brown communities can have screenings or healthcare accessible outside of the 8 to 5 hour Monday through Friday, because we know a lot in our community cannot access healthcare during that time frame. So there's really and that's a very loaded question. What's one policy? Wow. If I had my that's a really loaded question there, Renee.
Well, but you gave a lot of really good examples. But on the flip side of the food deserts, we have heard, and I think this where maybe Mr. Halligan can chime in too. We have heard of places that have set up little local grocery stores in areas where they have had food deserts, but then that food has gone to waste, right? Because they're not choosing perhaps to purchase the healthier items. So how big of a component is this on consumer education, and that they need to be educated about making wiser food choices? Is that a part of all this as well? And any of you can chime in.
Yeah, so let me speak to that for a moment if I could. First, the one thing that's important to recognize, someone doesn't choose to be hungry, right? It's a situation that oftentimes an individual is thrust into. It could be because of economics. It could be because of an unfortunate loss of family. It could be loss of job. It could be a health issue. There's a number of different factors that lead someone to be hungry. there's a number of different factors that lead someone to need healthcare assistance. One of the things that we've seen during COVID-19 is the importance of getting food into the community where people live rather than expecting people to go to the food.
Right.
Transportation is a huge barrier for many folks who are food insecure. And so a lot of the conversations that we've had as a committee over the last couple of weeks are, how do we help the Lexington Fayette Urban County government? How do we help businesses? How do we help other public entities understand some of the dynamics that an individual has to manage in order just to get food on the table?
Right.
So I think that's a really important piece of our work. And while, yes, we can talk about educating individuals on good choices in nutrition and all of those kinds of things, if they're worried about having enough money to pay for a bus ride to go get a box of cereal, we've got a bigger issue than just educating an individual on healthy choices. And Dr. Talbert said this very well early on. There are systemic challenges that we have to imagine and think about those challenges differently, so that someone who finds themselves hungry, finds themselves needing healthcare assistance and can't get there, we have to figure out how to get those services to that community.
Right.
One of the very successful programs that we've seen, to your question about food deserts, is community co-ops that have started to form in a handful of neighborhoods. And the thing that's beautiful about that process is that it's individuals in a community choosing to make a difference in their community for their community. How can we assist individuals in their community with how to manage a grocery store, how to purchase food at a grocery store, how to manage the cash flow of profitability to keep prices down so that more people can prosper from a co-op? Those are some amazing opportunities that we have here in Fayette County, and quite frankly, all across the country, that will make a difference in the lives for many. Those are the kinds of creative things that we've got to think about. Then we can work with people on better understanding nutrition, because they've got access to the food. Now they can actually think about the nutritious choices for that food.
Yeah. Dr. Talbert, you want to weigh in here?
Yes, I did. And my colleagues are all on point, and I love that. And I just wanted to add, and this had come up during one of our subcommittee meetings in terms of foods and vegetables and food selection. I think that one of the things, as Casey had mentioned, and as we reinvent and reimagine how we help people, is that we're including people in on those decisions. So I think that one thing about vegetables and purchasing and food selection is helping them to help decide what those selections could be, because there have been vegetables and different foods and things available to people that they aren't accustomed to preparing, eating. So therefore, they're not selecting those things because that's not the typical thing that they would prepare in their homes for their family. Right. So I think that the inclusion part of looking at what we do for health disparities, just like any of these other places, and I think health is so much more personal. It's about power, privilege, and access. So part of the empowerment of the individuals in the community is their representation, means, and resources, but also their inclusion on how the help and the solution is developed.
Absolutely.
Yeah, Dr. Williams?
Yes, absolutely, Dr. Talbot. And that the individuals within these communities, they have resources and they have the solutions to the problems that they're facing every day. But oftentimes what happens is we step aside and we step back and we try to provide solutions for them that doesn't work well for that individual community.
Mhm.
So we think it's just so very important to always hear the voice of the people who we're trying to reach and help them, empower them to be a part of the solution.
Right.
One of
We've
the
gotten set. Oh, go ahead. Go ahead, Casey.
Oh, no, I was just going to say one of the things that I teach my nursing students is that we partner with the community.
Absolutely.
It's always, we never come from a paternalistic. And so we have to meet them where they
Mhm.
are. This is
Mhm.
what you like to eat. These are the type of foods that you're accustomed to, either because of where you grew up. Let me show you now how to make it in a healthier way. And
Right.
so trying not to put necessarily all of our views and our Western values necessarily on everyone, but just this is what you eat. Let me now tell you the healthier way to do that. And so that's meeting them where they are, partnering with that community.
Mhm.
Absolutely.
And to that point, Ms. Casey Allen Bryant, we have a series of questions from Ariel Author, and many of them very appraised, and one of them in particular kind of starts where you stop there, Casey. She says the inequities in Lexington are significant and persistent. What steps are you taking to partner with residents most impacted by racial health inequities to identify, plan, implement, and evaluate structural inequities that contribute to poor health outcomes?
Which entity do you want to start with here?
Well,
Yeah.
you start with whatever entity
Yeah.
you'd like to.
Well, I can, and so I can say definitely in terms of the Lexington Fayette County Health Department, I mean, we do work with we have a whole team of community health educators that are partnering with various community organizations within Lexington. And we also have a CHIP survey that we've talked a lot about, our subcommittee has, where we do that every 5 years and have a sample of the community. What are their issues? What do they think that they see as in terms of the most prevalent health challenges in Lexington right now? And so we do get that input from our community members and trying to work with them.
And Vivian, you want to add anything to that?
Just that, now is when we think about forming committees and we think about putting together advisory groups, work groups, whatever you'd like to call them. Now we're thinking about really, how do you have that community voice, right? Everybody wants to, the term now everybody is using, at least in population public health, is people with lived experience. You want people that can speak to the issue. So we used to sit down and talk about, we think a community needs this.
Yes.
They'd be better off if we did this.
Yeah.
If we just put it there. So, but no one ever asked the community what they needed. So now we're trying to be more inclusive when we form these work groups, when we form these committees, when we want to launch a program, when we want to start doing diabetes education. And Casey said it, and Dr. Williams said it too. When we try to do diabetes education for our Latinx community, we often, and we've realized that we can't go in cooking traditional things that you and I would eat, because they're going to sit there with this blank stare as to, how is that helping me? That's not the palate that we're used to. That's not our culture. So now when we do our diabetes education classes, we incorporate Latin foods. Here's how you prepare this healthier. So we're beginning to listen, and we're beginning to have that voice at the table when we start making recommendations, putting in policy and programs. So that's just one way to kind of bring that expertise in. We could do more, of course, but I think that's a good first step, because it helps us to realize that the lens that we've been looking through is not the lens that the population is using that we want to serve.
Yeah, very good point.
Renee,
Yes, ma'am.
could I speak to that?
Absolutely.
And one thing that keeps coming up in our committee is the community health worker model. And those are individuals who are from those community. They have the same lived experience as the people who we're trying to reach. And what's even more special about them is that they're able to culturally adapt things. As Vivian was saying, we wouldn't want to come into a community and try to teach them something that's outside of their culture. We would want to culturally adapt it so it's something that's more acceptable to them. And that's a great strength of the community health worker model, and it's sustainable. Because another thing that we certainly want to avoid in our recommendations to the mayor is developing programs that are short-lived, and then the individual leaves and the program leaves. We want to recommend things that will stay, that will be sustained for years to come. And we believe that would have a greater impact.
What are some of those ideas you have, Dr. Williams, that would make that kind of transformation?
One of those things is the community health worker. And how we've spoken of this person is that this individual would not just navigate to resources, because a lot of times there are resources available in the community, but people simply are unaware of them. So that is an important thing that a community health worker would do. But that individual would also have an advocacy role where they're at the table. And when decisions are being made about perhaps building a neighborhood and looking at the plans and recognizing that this neighborhood plan has no sidewalks, that's when the voice of the community health worker can speak up and say that there are parts of Lexington where there's green space, there are sidewalks, and we need that throughout the city.
Right.
So
So
that's-
how do you, Dr. Williams, identify a community health worker? How do you recruit them? How do you identify them? And how do you train them?
Well, there are excellent job descriptions already written for community health workers. Many of the researchers, including myself at the University of Kentucky, use community health workers with the populations that we work with. And there are very clear job descriptions that doesn't necessarily have to be someone who has a degree, has a background in health education, but just someone who knows and cares about that community, that has influence within that community.
So we know that approach works. Where else has that been tried and has a proven track record?
Absolutely. It has been proven in research with interventions, and it's been proven in neighborhood community civic engagements, such as what we're recommending with the mayor.
Okay. I'm gonna, yes,
Can
go
I
ahead.
just say something about that?
Go ahead, Vivian, because she's kind of.
Or do you want to go to something else, Renee? Can I say something to that?
Yeah, you go ahead, Vivian. Yes, go
Okay.
ahead.
So I kind of wanted to expound a little bit on the community health worker model, and you know, it's an evidence-based program that's been utilized in our state in Appalachia for 20 plus years.
Yes.
Home Place with Fran Feltner. I'm sure you're familiar with that.
I-
So that model works. It works. The people are from the community. And we've established a credentialing program at the State Department for Public Health to where everybody's getting the same training. There's core competencies. There's standards and measures that have to be met. If you want to offer a community health worker program, you have to be accredited through our system at the Department for Public Health. And if you are a community health worker that you want to be credentialed in the state of Kentucky, you have to meet certain requirements within our state to do that within certain communities. So now we have something that puts everybody on the same level playing field. Everybody's been trained the same way. They've been taught the same things. They're singing off the same sheet of music, so to speak. When they go to communities, they're armed with the best information from credible sources, and they're able to really have an impact in their community. And we're recommending that we're not looking for that a person with a college degree and 3 degrees to go out. We're really looking for that person who just has a passion for health, who really wants to help their community.
Yes.
And none of that's required. That's the beauty of the program.
Yes.
Right now, we're trying to get them paid because many times our community health workers are strictly volunteer. So now we're trying to get Medicaid and our MCOs to kind of put some money to this evidence-based model to make sure.
Uh-oh.
Is that?
She's a little frozen. She was
There she goes.
great point. Okay, she's going to rejoin us. That was and Vivian just brought up a point that I was curious about, is the pay of these community health workers. And you mentioned, Vivian, right before we lost you for just a moment, that many of these community health workers are volunteers. So, and I'm very familiar with Fran Feltner's work. And so I'm just curious, what has to change? How do they get paid? Because certainly that would make a big difference in impact in the community if they were actually compensated.
Right. They're paid at all. If they're paid at all, they're paid through grants. We look for grant dollars to support their work. And we all know how grant money is. Once you have it, it's nice, but once it goes away, if there's no continued stream, you're done. So we were always looking for that next grant, that next pot of money to kind of feed the program. So they're either paid through grant dollars, or federally qualified health centers have taken that cost themselves. Hospitals have taken that cost on. But usually what you find is there's one for a healthcare system, or there's 2 within a large healthcare system, and that's just not enough. So we need to make sure that they have the number of folks that's needed to reach the communities that have the greatest need. And there's some folks that are trying to do that now.
So I just wanted to chime in because I've been wanting, and maybe Vivian will come back by the time I finish. But I think that the opportunity.
If I'm freezing up, but
Yeah.
hopefully you heard me.
We heard most of you. We'll come back to you again. Dr. Talbert.
Yeah, I just wanted to kind of echo with what some of my colleagues have stated in terms of the community health workers. And I think that that's also an excellent opportunity to talk about partnerships and partnerships with local hospitals and facilities, because one of the other things that we've done on our subcommittee is we've talked about that list of partners. How might we expand our footprint and our scope of the work that we do? And I think that it's critical to look at partnerships, because that's one added way to look at how these individuals could be paid. I mean, just because they're sponsored or standardized or the education comes from the Kentucky Health Department, which I'm totally for, doesn't mean that we can't find ways to fit them into various facilities with that certification and credentialing that is required to be effective in their role, but link it up to some model that's already existent in a facility that could facilitate and ensure that they had a salary, right? And I think too, you had mentioned earlier, Renee, about changing laws, ordinances, or whatever. I think we've really mentioned too, when you think of the codes, building codes or whatever in communities, and you think of our communities, and when we're building a new neighborhood, Dr. Williams, then there should not have to be a community health worker or someone who, yes, advocates for that community, but it should be without question that that's a standard for building any new or constructing any new community, regardless of the zip code, that there are sidewalks for individuals to walk on. So I think that when we look at that, I think that there needs to be some modifications made to building codes, housing codes, neighborhood codes that say these are the core things that need to be a part of any community.
Right. So are you also on the gentrification subcommittee as well?
No, but
There's tons of interlap, right?
We're going to have some recommendations for them.
Yeah. That's right too. The interconnectivity, the intersectionality, as we hear, right?
Social determinants of health. Yes.
Yeah. So I am curious about what other data are you gathering when you talk about health disparities, and we always hear, data makes the point, right? You can't argue against the numbers. So are you looking just at strictly mortality rates? Are you looking at rates of chronic illness? We know that COVID has really amplified the divides when it comes to Black and brown communities on infection rates and death rates. What is it specifically that you're looking at to say, this is really defining the health disparities here, and here's how we move on from that point? And anyone who'd like to, I'll let you jump in.
I don't think that we can talk about health disparities without talking about COVID. I mean, we just can't, because COVID has highlighted again that saying that, what is it? You guys could probably repeat this just as well as I can. If America gets a cold, white people get the flu, it's the same thing. And so COVID has just highlighted it. And so, I mean, that's just with it alone, that data and some of the barriers that we've seen just surrounding just surrounding COVID, that within itself is its own subcommittee, really, we could, because it has highlighted the same things that we've always seen. It's highlighted transportation issues. It's highlighted in terms of access to healthcare. It's highlighted the disparities in uninsured and uninsured. I mean, it's highlighted everything that us in the public health world have always seen, no matter what name you put in that algebraic formula, whether it's COVID, diabetes, hypertension, what have you. It's the same issues that we've seen with everything.
So I would like to add to that, and I agree definitely with Casey for sure. But in our, I think some other driving forces that we've used as kind of a platform to build our case. And I mean, obviously we'll need to put this together, and it's not at this point, but we had the community health assessment tools. Okay. So that's some groundwork, some feedback directly from the people in the community. And I think Vivian speaks best to the fact of the oversampling when they had done the last assessment, to really get a very robust sample size so that we could have feedback from African Americans. I think we have several subject matter experts that sit on the subcommittee, Dr. Williams, Vivian, Casey, Michael. I mean, we have a lot of people and others. We have a fabulous committee, and there have been many people by anecdotal information through literature reviews that Dr. Williams has done extensively. So, but also Vivian's department, what she heads, I mean, she has a really good, we have a minority health status report for the state of Kentucky. Now, granted, you know, looking specifically at Lexington, but I think we could easily extrapolate some of those things that are some of the same issues in terms of, you know, women and breast mammograms and the screening. I mean, less than 20% among Black women. Also, the fact that we look at Black and brown people, Hispanics, colonoscopy, pap smears, all these things that are screening entities that help save lives and prevent further illness. We know that individuals in Black and brown communities through these reports are not getting that type of pre-work or screening. I think dental care is another thing that stands out with that, you know, either from the lack of insurance or the, you know, ability and access to do those things. So I think that there are other great reports out there that we can compile and use as we look at risk factors to those in the community, as well as health outcomes in the literature.
And Vivian, I wonder if you could speak on the challenges that we're having with data.
That's exactly where I was going, Dr. Williams. Just read my mind. You know, one of the things I would like to see is right now we don't have standard data elements that are collected, meaning everybody can collect different things. Each hospital system, each MCO, it's not required through Medicaid, the race ethnicity be captured. So when we really try to look at the data and see what's going on in our communities, I have to report the data's unavailable. The data's not there. That's very frustrating when you want to advocate for something and you want to show people the need. But like you said, in my world, if the data doesn't show it, it's a mute issue. So what I'd like to see is that from, you know, anything that has to do with healthcare access, or anything related to communities of color, that data be captured. Start collecting that. That's standardized. Everybody has to do it. And that's been a big push. We still get pushback for that because data systems that people have paid for and that they've been using for years to modify those systems, it's a cost. So that's the pushback we get sometimes. The other thing I wanted to say about data too is we've got a lot of data tools now at our disposal. And I think I shared this with the group. It's called Social Vulnerability Index. And it's a tool that looks at certain areas by census tract within your county to see where the hardest hit communities lie, meaning where are the most impoverished, where is segregated housing, where is lack of transportation, and where is the least resources being placed, and overlay that with hypertension, diabetes, heart disease, and overlay that with COVID. And you can see those with the greatest risk exactly where they are down to the street. And I think we need to start utilizing some of those data tools that we have as resources to really have people to say, okay, instead of putting all of these resources and money into 40511, let's look at Anderson Street, Johnson Street, Elm Street. This is where the majority of the folks with all of these comorbidities and all of these other issues are found. That's, to me, responsible programming. That's really putting the money where it needs to be put. Instead of giving everybody the same, we're making it equal, right? We're not making it equitable, right? And you know, we've talked about that a lot, Renee, on the difference between making something equal and something equitable. So, you know, I'll let someone else talk now.
No, that's good. That's good. So we've got a few questions. I'm going to sprinkle these in. It's a good conversation. I know I'm learning a lot, and I hope everyone else is as well. And that's what this exercise is about, all of us learning together. So this is a really good question. How can the city help with the gap of Medicaid? Example, dental is only cleaning, but if one needs other dental work, it's not covered. I don't have enough funds to get the help needed. Now you're sick from the tooth problem. Now you're at the ER receiving care from the emergency room. So we can see how there's a domino effect there. So Medicaid, we know, is a federal state program. So maybe there's not much that the city can do with that, but I'm not sure, Dr. Talbert, Dr. Williams, and even Vivian and Casey. What would you say to that?
Well, one thing that came to my mind when I heard that question was dental schools. The University of Kentucky has a school of dentistry. And the students in the dental school are a great resource for providing that kind of care to the citizens of Lexington and Fayette County. And I think that those partnerships, the development of those very clear partnerships will take us a long way in addressing some of those dental care needs.
And
There is always, oh, go ahead, Casey.
No, I was going to say, I hate to take the conversation too global, but a lot of what we've talked about is just policy change.
Yes.
And so, and it goes back to empowering our communities to advocate for themselves. And so what I was going to say is write your legislator if that's what you want. Really, I mean, really, it's these are policy issues. And so if you notice, a lot of what themes that we're going back to is policy, policy, policy. And so we've got to kind of start there.
Yeah, I agree. That's my wheelhouse right there. And I'm always preaching that, right? That policy makes the impact on the people. And we know that from a Medicaid perspective, you know, we had proposals before the current administration, right? That would have affected access to dental services, even though that was backed off. So we know that, you know, that's an evolution thing that happens with administration, Dr. Talbot. But oftentimes, you know, healthcare and access to healthcare is the crux, or many people assume to be the crux of health disparities, right? If you can't get the access, then that already puts you at a disadvantage. So are there any policy recommendations you have from the access perspective in healthcare and expanding healthcare coverage beyond the current offerings?
Well, and I think that also we have to think about and operationalize healthcare too, because I think oftentimes people believe healthcare has to be what you receive in the hospital or in a particular setting. So I think that with my colleagues here and other people, as we think about what people need and how we provide that and direct them to the services. I think back to the healthcare worker model or the community worker model, as well as just what resources are available in the community that people don't even know about or access. And then looking even more basically at stepping back and saying, and what are some of those other social determinants of health that prevent them from getting there? Because even though some things may be in the community, if it's a mile or 2 miles away and you don't have a car, it's still a problem. So I think that we have to get even more basic. And I know one of our subcommittee members had talked about the fact of looking at, you know, place-based programs to pilot. And I think that as we include more of the people in the community to talk about what it is that they believe they need, and if that's dental care, okay, well, how do we make that happen? How do we make that partnership with the University of Kentucky and the College of Dentistry? You know, how do we do that and bridge that gap? And I think with working with individuals such as that in the community and the partnerships, we could make that happen. And for the coverage piece, again, I'm back to what Casey said. I think we have to legislate because we have reached a point where I believe the nation, the city, the state is awake, right? People are awake right now. So we have to use this momentum to look at policy being based on the science and the research and not the politics, right? So I think we have to leverage what we can get for what we know and what we're seeing.
Yeah, very good.
I have a question. How has the committee addressed mental health and the, you know, being an educator, and I've seen so many parents struggle with children who need services. And so how has that been addressed in your subcommittee?
Does anybody want to talk about that, ladies?
So let me, if I might, let me share kind of an interesting conversation that we had in our last meeting. We had a poignant story from one of the members about the community. And it boiled down to trust of healthcare. It also boiled down to having availability of healthcare for someone that an individual is comfortable with. someone who has similar experiences, someone who looks like Michael Halligan for Michael Halligan versus someone who looks like Dr. Gerald Smith for Dr. Gerald Smith. And the ability for someone who looks like Dr. Gerald Smith to find a healthcare professional that has similar color of skin, similar background and experiences is far more difficult than it is for someone like Michael Halligan to find someone who I can build a relationship with and someone who I can trust to start with. With mental health, it gets even more difficult. I don't remember the exact statistics that we ended up talking about, but it was something like 5% of healthcare professionals are African American. And in Fayette County, 15% of the population is African American. So it's far more difficult for an African American to find someone who they may trust than it is for me, if part of that trust is based on two people looking more similar. And I think the conversation that we ended up having in the mental health area, and correct me if I'm wrong on this, team members, but I think we talked about there were four healthcare professionals in Fayette County that dealt with mental health issues for people of color. Very, very difficult. So how do we advocate? So this kind of gets back to the policy. How do we advocate to change that systemic bias in the availability of professional development of one type of community member versus another? And that's a big long-term challenge, but it has to start with us understanding that it's about relationship and it's about trust. And if our system is based on primary care as the starting point for healthcare, how do we ensure that there are primary care physicians available for everyone? And the poignant part of the story that we were told is an individual was coming into an office asking to seek a certain type of doctor for their support. And the response that they got from that office was, "We don't do that. You have to see who's available."
Mm-hmm.
That simple statement has to change. It has to be about customer service. It has to be about what Ms. Allen Bryant said earlier. We have to be able to meet people where they are, not treat everybody equal. And it starts with building that foundation of trust. And it starts with advocating for changing the system of growth for professionals in the field so that there is a more equitable, a more diverse set of individuals to provide those services.
Right. And perhaps it's even to Doctors Talbert and Williams, also training primary care physicians on recognizing mental and emotional issues, right? Instead of just asking, well, what's wrong with you? Asking, well, what happened to you, right? Getting at what the background experiences. I've just finished a special report about adverse childhood experiences. So I'm all about that life right now. But it's very true. And I've done the research on Dr. Ferlitti on ACEs and how important that is in your biological and physiological outcomes. It can shorten your life by 20 years if you've had traumatic experiences and toxic stress over and over again. You know, and when we think about school policies that are, very hard-edged on school discipline and expulsion. You know, if a kid brings, I've heard Manny Cox say, if a kid brings a gun to school, perhaps there's a reason why that kid is bringing the gun to school, not because they're violent, but they're trying to protect themselves from violence, right? So just kind of reframing our whole perception about people's environments, not just their home environment, but their community environment, and how even primary care physicians need to be able to recognize that, and also growing a profession that has a representation of the people that it's serving. So how do you get at all of that through this subcommittee?
Oh, Yeah,
Yeah,
that's very challenging. It's a
yes,
big,
that
it's a
it is
tall order.
indeed.
It's a heavy lift. But I'd like to add to that. While I think it's important, and what Mr. Halligan is referring to, and what we've often called, and you'll see it a lot in the literature, is physician-patient concordance. That agreement, that alignment, and having people of the same race and ethnicity caring for patients. And while I think that there's some beauty to that, and I believe it's important, so I don't want to undermine that. But what I don't think we need to do is establish the expectation that only some people need to do what's right for the patient, and can present themselves and be expected to have some cultural humility when caring for patients that don't look like me. So I believe that while we go at this at both, you have to go at it both ends. Everybody, we have to look at some, whether that's legislation or working through the various boards that certify and license physicians, nurses, psychologists, pharmacists, the whole nine. What can be legislated there at that level to change how people, one, even trained. I mean, I don't know for licensure requirements how much it would impact, but you can certainly look at it from that perspective as well. But also just the training piece. I mean, if nothing else, universities need to look, especially our allied health professional colleges, at how do we train people to be culturally sensitive, or to give culturally sensitive care, to have some cultural humility. So I think you also have to go that in, because it can't just be the Black people taking care of the Black people, and vice versa, because right now we don't have the pipeline nor the spread for that, right? We don't have it, but certainly I think you leverage it when you can, and in the community. And I think that based on what Vivian, just what she was talking about, when we see these at-risk populations by zip code, and we know that, and we know the population density as it relates to African Americans or what have you, Black and brown people, why can't we have some intentionality in those spaces in terms of who we have caring for those individuals, and how we navigate them through the system to help intentionally ensure that they have some physician-patient concordance.
Right. And as part of the continuing education requirements that I'm sure physicians have, I mean, how much is implicit bias and cultural competency a part of those types of agendas?
Well, we don't have a physician on this board.
Casey, go ahead. I'm gonna let you have.
Well, we don't have,
ready.
we don't have a physician present at this moment, but I can tell you that it's probably not much of a requirement there. Heck, now I'm putting that nicely enough, Vivian. Or Takia. Yes, I think it has been left to many of your programs, your individual programs, how much importance did they put on that implicit bias training and that cultural competence and cultural sensitivity training. I can only speak for our College of Nursing. That's what I spend all of my time with my undergraduates doing, but I can't say that for every single college. I can't say that for every College of Medicine or what have you. So, could you legislate that? It would be great. Again, we're lobbying and writing legislators comes in. I'm a big policy person, so.
Right.
Well,
No, can I say something here?
Yes, Dr. Smith.
Yeah, I have been listening, and I appreciate the conversation as we've addressed environmental issues and economics and education. But as a historian, I think it's vitally and critically important that we address the reality that medical racism exists, one, and that there is a long history to that medical racism dating back to slavery, that historically, the Black body has been this involuntary site of medical experimentation, dissection, and exploitation, and it's carried over well into the 21st century. And because of that, we have this continuing distrust factor between patient and physician. And so that's why the implicit bias training is so vitally important as we move forward, because many of these physicians who are being trained really don't have any knowledge about what has taken place regarding the Black body historically, going back to slavery. I mean, even in terms of mental health, I mean, there was a psychiatric diagnosis that the slaves who ran away had something called drapetomania, which was simply the disease that caused slaves to run away. During the civil rights movement, there were psychiatrists who were saying that these people who are engaged in nonviolent direct action protests must have a mental problem. And so, those are things that we have to, really more fully examine, and understanding why people of color are reluctant to even, visit the doctor's office, knowing that they are coming out of this historical and collective memory that, they've shared and heard from, their grandparents.
Thank you, Dr. Smith, for that. He's always good to put things in a context that maybe have escaped us so far. And that was a very important point to make. And I do want to ask the healthcare experts, how do you go about upending that fear, perhaps, that still resides with many who remember and know of Tuskegee experiment, et cetera? And even before, way before, as Dr. Smith just illuminated for us.
I think definitely.
Go
ahead, Dr.
No, go ahead, Casey.
I was just going to say, definitely reaching out to our local communities. On other Zooms that I've been on, when COVID first, we started seeing the disparities in COVID with African Americans. I talked about this. We have things in our history like the Henrietta Lacks story, where they used her cells for thousands and thousands of experiments unbeknownst to her family, and definitely without her permission. And, we take that back to present day. You're not sticking no swab up my nose. What are you doing with that? Just having that trust with these community leaders to say, hey, this is just a test for COVID. We're not going to be using it for anything else. Working with these communities to have that communication, because instances like the Tuskegee experiment and the Henrietta Lacks stories, those are playing in the back of some people's minds. They may not know that that's what it is, but what they may have heard their grandmother say is, don't trust those doctors. They're playing with your stuff, that kind of thing. So, even though they can't necessarily name what exactly experiment happened. So again, just going back to communicating and acknowledging that I understand that you may have some distrust of what I'm going to do with your sample, for example, if we're talking about COVID testing, for example, but acknowledging it and doing our best to develop those trusting relationships so that we can dispel these myths.
Yes. Yes.
Dr. Williams?
Yeah.
I was about to say that one thing I learned very early on in my career is that people don't care how much you know until they know how much you care.
Yeah.
And one thing that Dr. White said that just really resonated with me during one of our subcommittee meetings was that we have to be persistent. We can't drop in and out of these communities. We have to have an engaged presence there. And that's how they know that we care about them. And so when we're doing health screenings, or we're bringing in the mobile van for mammography or blood pressure screenings, that we make sure that we keep it up. We don't just drop in once a year and do the screenings and, see you again, who knows when. We just have to be very consistent in what we're doing and the time that we're spending with communities.
Right. Vivian, yes. Ma'am, you can start. And while you're getting unlatched, I was just going to say, when we think about these one-off health fairs, what happens in the follow-up of that until you come back next year with the van,
exactly.
right? What have they done in the 364 days since? Vivian.
Yeah, I'm not a big proponent of health fairs. I'm just going to put that out there. So yeah, because of that reason, you come in and you have this big screening event, you have this health fair, and then there's no connecting the dots for people. So they get their blood pressure taken, they get their cholesterol, they get their finger stuck for their hemoglobin A1C, or they get, so you give them a piece of paper and you'll say, this is what it was today. Thank you for coming through our health fair. And they're looking at you like, okay, what does this number mean? What do I do now? Do I need to see somebody? How do I follow up? So there's a lot of things and a lot of information is given. We kill a lot of trees at health fairs, and they come home with a bag full of pamphlets, and they put it over there and it sits next to all the other bags they've got from their health fair. So I just think it's just not the most effective way to do things. So I think we really do need to think about trying to get back to something you said, Renee, and I want to kind of think of a way to kind of address some of those trust issues. Is a lot of hospitals and and healthcare systems have their community review boards, internal review boards that are made up of people of color, so they can understand the importance of clinical trials. They can understand the importance of things that are impacting them. So, and I haven't seen Lexington Fayette practice that. Now, I may be wrong. Somebody can correct me, because there's 3 people with UK Healthcare. I've never known them to have a community internal review board where that information is translated and disseminated to the public, where it makes sense to them, why they understand the importance, why they recognize the need, because there's not enough data of what happens in African-American women based on a certain issue. Why don't we have that data? We don't have it because of XYZ. And I think if we kind of back up to something Dr. Williams said, and even Mr. Halligan, is, trust is critical. If you own up and be transparent, and I think I've shared this with Dr. Talbot, if you recognize and say, yes, historically we have done XYZ, but moving forward, here's how we're trying to have a conversation with the community now to move forward. And we're trying to be more inclusive, and we would love to hear what you tell us you need versus us telling us what we think you need. So I think there's opportunities there for us to really think of ways to bridge that gap, because it's crucial. If you don't have the trust of a community, I don't care what you try to do. If they're not with you, you can talk to your green. I mean, it's just not going to move anything. And I think that goes back to the partnerships we form. We have a lot of coalitions in the city and a lot of groups, Kentucky Youth Advocates, people that are really working to address some of these issues, but we don't listen to each other. We work in silos. And we find out, I didn't know you were doing that, Ms. Akins. I didn't know you were doing that. And we find out after things are put into place that if we'd have really just had a conversation to know who's doing what, it would be beneficial to communities, so they know where the resources are, they know who's doing what, and they know who's looking out for them and who has their best interest at heart. So
I think a good convener of that would be the Foundation for a Healthy Kentucky, of which you are the vice chair, right? Vivian, I think that's an idea. Maybe that's something we're talking about. And the point about
it's an idea. And we have something in the works that we're working on, Renee, and I'd love to share with it another time. We're working on doing just that. And that's kind of unifying those folks across the state that are addressing healthcare issues. And we're really focusing on access, because the governor is determined to make sure that every Black and brown person is connected to some type of insurance, that there's some kind of coverage. So we're working on how do we make that happen? How do we ensure that communities that need that the most are connected? Does that mean we bring back the exchange? Does that mean we bring back connectors? What does that look like? So we're having that conversation now. So hopefully in the months to come, we can share some things on how that's going to move forward and how we're going to make sure that if access as relates to coverage is an issue, then that goes off the table now, because we've done due diligence to make sure that everybody is covered in the state of Kentucky.
And we know the governor has announced some intentionality and also addressing health disparities, right, and setting up a special task force to do that. So a lot of collaboration happening. Let's just get all the collaborators collaborating together, I think, is the main thing. So we do have several questions, and we'll try to get through these. And if you want to send a question, townhall@lexingtonky.gov. This comes from Councilmember Susan Lamb. She says the community health specialist position, which you all call the community health worker, I assume that's the same thing, that has been discussed, should be built into our existing paramedicine program, so that when our public safety professionals go out to deal with the vast issues in our community, they have all the resources necessary to be more effective. Has this been thought out? Sincerely, Susan Lamb. Thank you, Councilwoman.
Interesting.
Have you all thought about that?
No, I'm not sure I'm fully aware of everything. I'm vaguely familiar with the paramedicine program, but I think that goes back to Vivian's point about how we have pockets of excellence, and everybody doesn't know what everybody else is doing. So it's hard to even know who owns what to be able to expand off these different things. It seems they may be a little different, those programs, as I understand it, but I don't know. But I think that anything is worth exploring. And I think that's something we can certainly, consider to see how those could leverage and what synergy we could get.
Yeah.
You know.
Another question, don't have a name attached to this one, just an address. Black families have a fear of nursing homes. How could this committee address the education of nursing homes care? Are seniors living by themselves and not realizing that they qualify for services that their health insurance can pay for? Example, home health nurses being able to come into your home to help with needs or family care. Casey?
Well, that's a loaded question too, because again, that goes back to educational component, because what people don't understand is not everyone qualifies for those services where people come in to help you with your baths and help you with bathing and things like that. That's actually a subset of home health that you have to either privately pay for, or you have to be eligible for Medicaid. And as we know, the Medicaid, our population generally, you have to be at a certain income threshold for that. And so again, that goes back to education and the community health workers to let people know who's qualified for what resources. I don't think people quite understand that. In fact, with nursing homes, now I've been out of the home health game for a little while, but when I was in it, Medicare only paid for nursing home care so many days at a time. And I do believe that is still correct. And again, that's going back to educating our public.
Revisiting the conversation we had earlier about healthy food and food deserts and food insecurity, a question came in about how can the mayor have impact with that? And this person says they like the recommendation of using UK dental school, but it came right after a conversation about lack of transportation, et cetera. Are you making any recommendations, subcommittee, related to bringing UK's resources closer to the community, maybe utilizing city buildings temporarily? Thoughts about that?
That's great. Vivian, I remember doing one of our early subcommittee meetings. Someone told a story about going to the doctor's appointment and using public transportation and riding the bus for 2 hours. And I was just astounded by that. And so the subcommittee had some very rich dialogue about whether we should make a recommendation about having a medical route. And then, Michael, you had a very good idea about a cost analysis of looking at the Lextran having a medical route versus contracting with Uber or Lyft to see if that could be cheaper. But we have looked at transportation and how to best connect the person to the medical care if it's not available within their community.
Michael, you want to expand on your idea?
Yeah, so a little bit of what we talked about, it was kind of interesting. We had that story about taking buses and mass transit and public transit and having 2 hours just to get to the doctor's office. We hear the same thing all the time for folks that are food insecure getting to a pantry. And in today's fast-paced world, none of us have the time to go from bus A to bus B to bus C to bus D in order to get from point A to point B. And so how can we reimagine public transportation services that are point to point? And how can we look at the funds that we have today and how we spend those funds and reimagine spending them in a different way that's more about a route, or I'm sorry, less about a route and more about point to point. And if we think about the taxi cab approach in large metropolitan cities 10 years ago, and what Uber and Lyft and other private business carriers have done today, it's all about point to point transportation, and it's all about picking someone up at their home or where they're at and getting there. Where do they go? And you don't have to go to the street corner in order to get the service. And it seems to me that taking a step back and analyzing how do we spend money in a way that is about serving point to point, we could have some very different breakthroughs on how we spend our transportation dollars and how they better then support folks that are very transportation limited with their own resources. They don't have a car. If they don't have a car, they can't go point to point with the systems designed the way they are today, unless they have the economic resources to use an Uber or a Lyft type of service. How do we change that? How do we study it so that we can find a different way to do it?
It's a very good question. I hope the other committees, that transportation, is that a subcommittee? Is transportation a subcommittee? No?
And we did have some conversation though about bringing healthcare resources to the community, such as we've seen with examples like the COVID testing going to Shiloh or to Cardinal Valley. So we have had a little discussion about that. You don't always need a building. Sometimes you just need a parking lot. I mean, really.
Yeah, I've been there on that very well.
And maybe just to build on that point, because that was a really interesting conversation our committee had here a meeting or two ago. One of the stories that I shared was the difference that we saw when we found ourselves needing to do curbside distribution and mass distribution of food in a parking lot in a community. And I'll use Cardinal Valley as the example simply because it's a good illustrative example. When we started doing mass distributions in the Cardinal Valley neighborhood in partnership with Community Action, the individuals and the families that were coming to receive food assistance looked different than what we typically saw in one of our pantries. There were more individuals from the Cardinal Valley neighborhood. There were more individuals who were of Latino, Hispanic, Spanish-speaking backgrounds. And that was an eye-opener for me. And it spoke to bringing service to the community and working with the community to provide that service and to develop that service in the community. And that, part of that was the transportation conversation, but part of that was services need to build within the community for the community. And it starts to address the trust. It starts to address better dialogue. It starts to address relationships. It helps us all better understand one another. It's meeting people where they are. It's not trying to treat everybody equally by saying, go to this place for this service. Let's get the services to people and let's make it easier for folks to get to services if they're not in their neighborhood today.
Yeah.
And that's where that whole conversation went within our committee.
Yeah. If I can, I'll go to another question. This from Dr. Scott Keel. Says, thank you all. You've all spoken about community engagement and involvement to build healthy outcomes. One must help build community wealth. Having navigators, ambassadors, nurses from the community is perfect, but when you build roads, sidewalks, playgrounds, community gardens, and grocery stores, and much more in these communities, should contracts and bids be given to those that hire a certain percentage from within a certain radius of the project? Could this create community responsibility and shared interests? Says, I'm new to Kentucky, but free community college should also be on the table, and free classes such as the trades, healthy cooking. I'll save free access to water and cell phones for telehealth, etc. for later. And it said, then he says, did you say you need a doctor on the committee? He. Thank you so much. Stay well mentally and physically, Scott Keel. So if you need another doctor, perhaps you might want to reach out to Dr. Keel. You may know him. So he had a lot in that. I'll let you all respond as you see fit.
Well, that is certainly something that our economics committee is looking at concerning minorities, African Americans, and how many are getting the building contracts and things like that. So that is something that is truly being looked at by another subcommittee. And as we said, many of these committees are intertwined, and but that has been something that has been looked at through our economics committee, subcommittee.
So this
Can I just say something, Renee, about that to answer his question? To kind of piggyback on what Ms. Akins has said, because I was on that discussion at the Economic and Education Town Hall, and they were talking about the Mayor's Training Center and micro city government and how those were models that had worked in the past. And I shared that with our committee, and one of our committee members was saying how impactful that training center was for him to instill in him that economic piece, to be the provider And when you can provide, he said, that's your mental health. When you can provide for your family, put food on the table, you can think about health, right? Because we know that only 20% of healthcare impacts true health outcomes, right? There's so many more things that impact your long-term health, right? Stress, physical environment, your mental health, all of those things. So he was saying how instrumental those programs were for him coming up and how those were good models to kind of answer that physician's question about what are we doing with the economic development piece? If we're telling the community that we want to bring these markets in, or we want to bring grocery stores in, then how can, or we're bringing other economic businesses in, how can we make sure that the community members get that training to where they can work in those businesses? Maybe they want to start their own business, but where's the training piece? Where's that growth? Where's that leadership piece to show them how to do that, how to sustain that? And I think that's what we need to consider, because he was just saying how impactful it was to him. He was only 14 years old. And the impression that made at 14 has carried him through life now as an adult. So I think we really need to think about these things that we put in place for our youth, and for not only our youth, but for our adults as well, and how that's going to impact long-term health. What are we doing now and putting in place now that we can, 20 years down the road, we can see what an impact that's had. So I don't want to sound too preachy, I'm sorry.
No. Ms. Akins, do you have something to share there?
Yeah, let me say of a partnership, a health disparity. We know one of the major health disparities is that there are not enough African-American doctors. And we talked about that trust issue. You've discussed that. BMW Academy has just entered into a partnership with the medical school at the University of Kentucky. And there's a national organization called Black Men in White Coats. And so we will have a conference this year. We're going to identify 6th graders and start training them and getting them involved into becoming doctors. So I think that's how we're going to have to tackle the problem. We're going to have to start with our young people, educating them, exposing them. This program, we're hoping out of it that we are able to get 10 to maybe 15 doctors out of this program.
Wow.
I'm glad to hear you say that, because I was listening, was it Tuesday or Monday?
That's
I was
excellent.
listening to you talk about how you were growing your own teachers
Yes.
within the BMW program. And so that's great that you're also, reaching out to the medical as well.
And when hopefully, we're hoping if the pandemic is over, there's going to be a big conference and they are sending national people in. Each young man who's in the cohort will have a doctor at UK who's a mentor. I mean, they have an excellent program. We're so excited about this partnership. And I hope many of you we will invite you to the conference, because it is for the community, that this could be another way that we raise our own doctors as well.
Yeah. Congratulations, Roz, on that. That's a wonderful idea.
It is. And I wonder if we could leverage that to train nurses, male nurses.
Yes. And Fayette County now has the girls STEM program. So that could be one of the ways of a partnership with the STEM program and get us to have more nurses.
Yes.
So they would love to have that partnership. Like the Brenda Cowan School has been adopted by the fire department. So they're looking at training, policemen, firemen, those kinds of things. But this would be an excellent opportunity, Dr. Williams, with the new Girls STEM Academy.
Yes.
I wrote that down. I will be.
I did too.
The other thing too, is the academies that have been set up at our high school now.
Yes.
Bryan Station has the healthcare focus. So I think that's another opportunity for us to tap into the students that are in the healthcare track at Bryan Station High School. So I mean, there's to me a lot of opportunities to make those connections, to make sure that we understand that we're kind of grooming our own, right? And that academy, 2 years old now, so.
Yeah. Dr. Smith has a daughter who's in medical school who came up through the Fayette County public school system.
Yes, I have a daughter. Our youngest daughter is a 4th-year med student now. And so one of the things, I was just listening to the conversation, one of the things that I'm real concerned about is making sure that we sustain that momentum, that once they begin in the 6th grade, getting from the 6th grade to that 4th year of med school, there's a lot of in-betweens. And
Yes.
so we've got to make sure that there are the right people in place along the way to sort of nurture and encourage them to get to that dream of becoming a doctor. Because, you know, what I have witnessed, quite frankly, is that a lot of times these students don't have the sort of support structures in place that can guide them and encourage them when they encounter those roadblocks. Something's missing there. So we've got to make sure that we cover that missing link between, let's say, the 6th grade and becoming a medical doctor. I mean, there are advisors involved. There are individuals in place who do not necessarily have the same passion and concern that, you know, that Ms. Akins has, that along the way can sort of sidetrack those students who may encounter some sort of obstacle in life. You know, things happen, and we've got to make sure we've got that individuals along the way to encourage them to never give up.
Yeah.
Yeah.
And keep them informed about other resources. I
Yeah.
mean, that's the other piece of this. We've got to make sure that we connect them not only with the mentor, but also making sure that we're connecting them with other people at the college that they're attending. You know, that they understand and are aware of various organizations, like MAP, for example, you know, the Minority, I think it's Minority Application Pre-Medical Student Association. There are those kind of organizations along the way that can help even undergird what they're trying to do.
Mhm. Good.
And it's just been real interesting just sort of following our youngest daughter through medical school and getting a sense of the kind of support system that is in place at the school that she's attending now. It's just amazing.
Good. And she's got a good support
I
system.
also want to point out too that she does. I wanted to point out that we were talking about a pipeline, and I don't want us to forget our HBCUs.
Right.
That we have, you know, an opportunity there that I don't think we capitalize on enough, and work on that partnership with now Simmons and with Kentucky State University. So I want us to kind of remember that they're right in our backyard. And I think we forget that sometimes. So
And that's such a good point, because, you know, we you know, I say this respectfully, but we don't need any more coaches. We don't need any more basketball, football players. You know, we need doctors, we need nurses, we need engineers, we need attorneys, we need teachers, and so forth. And so I don't get excited about coaching programs or athletic programs. That doesn't motivate. That's not going to change where we are right now as a people.
Here, here. Ariel Author followed up on another point, and it's a good question, because Vivian, you just said this a few moments ago, that healthcare only accounts for about 20% of health outcomes. And so she asked, regarding addressing health inequities through policy, Lexington should consider having all items put before City Council reviewed for their impact on racism and health disparities. Does the subcommittee advocate for that approach? Why not, right?
I'll start with that one.
Yeah.
Okay.
I'll start with that one. We were trying to do something with our legislators in Frankfurt to really think about, before they propose any legislation, Renee, and I think you could appreciate this, that they think about whether there's a health disparity impact, whether there's an equity impact. You know,
Racial
just
impact.
because you think it's a good piece of legislation. Exactly. We do them for we do fiscal notes. We do things that look at the economy of it. Why don't we do the same thing for health? Why don't we do the same thing for looking at social determinants? Why don't we do the same thing for looking at whether it's an equitable piece of legislation? And that's been hard for people to kind of wrap their head around at the Capitol. But I think it's absolutely what we need to do. And I think moving forward with city government, just like with state government, with local government, I think the same things. You know, when you want to put, let's say a bus station wanted to be behind a neighborhood, or let's look at an industry. Look at Rubber Town in Louisville as an example. Industry right behind a African-American community in Louisville. They did a health impact assessment to determine that wasn't such a good idea, because now we've got increased asthma, we've got a lot of respiratory issues. So there are things like that if it had been thought of in the beginning, then that would have never happened. So I'm trying to get us to be proactive in thinking before we make decisions. Let's think about the communities that might be impacted. And I think Ariel's got a good point. I think we do need to make that part of how government works moving forward, local government anyway. I'm still
Right.
trying on the state side.
Well, and Senator Gerald Neal of Louisville has put that bill forward at least 2 legislative sessions for a racial impact statement, because there is no
Yes.
racial impact statement on anything. Criminal justice, I mean, there have been bills that have passed that General Assembly where it directly would disproportionately affect minority communities of color, and there was no racial impact statement done on that. Right. So I think that it's across the board, but I do think the impetus may be there for this session, considering what's happening in our own backyard, or at least 79 miles west of us, right, in Louisville. So I think that there may be some impetus for that on the state level, and maybe you all can make it happen on the local level in Fayette County. This question from Reva Russell English, I'm just going to get to her question. She makes some really good points and points to some studies that I'm going to look up. But she asked about whether or not elected officials are planning to reprioritize how and where we spend money to address these root and interconnected causes of health disparities, given that looking at solving health disparities as an isolated problem will likely do anything to improve them. So this kind of circles us back, since we're almost about 7 minutes before the top of the hour, you know, interconnecting and the intersectionality of all these different things, as we've talked about. You can't look at it in a silo, that all of this stuff is connected. Transportation, health, education, criminal justice, is all meshes together. So what do we know about elected officials' plans to reprioritize? Have you all had any conversations on that front?
No, we have not had any conversations on that particular front. I mean, once we finish the report and present it to the mayor, I'm sure there are going to be some recommendations that are going to require council action. It'll be interesting to follow how they're going to respond to those recommendations.
Right.
You know, there are elected officials. We'll get a sense of where their values and priorities are based on how they respond to some of these recommendations. So this is going to be revealing in a number of ways in terms of what kind of community we envision living in.
That's right. Any other comment to that? That's very well stated, Dr. Smith, of course.
You know, maybe one thing I would add as a committee member, what's encouraging to me, and this kind of goes back a little bit to the question here a moment ago, oftentimes when an analysis of an opportunity is done, it's a business analysis. It's about return on investment, right? And what's encouraging about the very fact that this commission was formed and the impetus for this commission, it's about equity, it's about diversity, and it's about inclusion. And none of those are business rate of return. They're about how do we care for one another so that we can improve the world that we live in. And the very fact that we formed this commission to have these dialogues, to do this deep thinking, gives me great hope that not only the mayor, but our council members will take the input and will do the fiscal analysis that needs to be done, but also will do the human analysis that has to go with it so that we find ourselves in a better place. This is the beginning. And I think Dr. Smith said it very, very well. What comes out of this commission's work, the changes that we start to see, will tell us whether we've started to advance or whether we've got more work to do to advance.
Very well said. I do want to ask, and this was a question that Ariel Arthur had also posed, and it's a good one, about how you can engage youth in this process, or have you heretofore engaged young people in this process?
I think one of the things, I know Vivian and I talked about this in one of our discourses, that's probably something in this particular subcommittee we could have done a better job with. I think that when you look at the subcommittee in totality, that there's been probably some angles and voices there. I think that we have had maybe that second-handed in our space, but we really haven't looked at kind of some of the age-related specific things, especially as it relates to the youth, let me just say. So I think that that was, that's an area of opportunity. And I don't know, others may feel differently about that, but we had talked about that. And I think that that's something we could have done a little differently in terms of our composition and or consultation to the subcommittee,
Mhm.
which is still time for that, actually.
Sure.
It's not, I mean, we're not through this process, so.
Anyone else care to speak on that? Or with 3 minutes remaining, we can kind of just give an overall vision to our co-chairs, if you can, in a minute apiece, maybe, Drs. Talbert and Williams. Tell us what you'd like to see come from this work in this subcommittee, and in kind of conceptual terms, what you hope will be the real meaning of your recommendations.
Gloria or Dr. Williams, do you want to start, or you want me to? We only have a minute apiece.
If there was one thing that I would like to see come out of this committee, or the time that we've spent, is that the voice of the community be heard loud and clear, and that any recommendation that we put forward is something that's very impactful to the health of this community and sustainable.
Yeah.
I like that. Yes, I like that. And I think that one of the things, and I think Vivian and everybody else will appreciate this, one of the things that I hope that we can put forth is a source of truth. And when I say that, I'm thinking from a data perspective, because we have to have some standardization in that space and be able to tell the story. And I mean, we have plenty, I think, through what Dr. Williams had stated in terms of the people and the voice of the people, which is highly critical. But I think the other piece of that, especially to impact policy, we're going to have to be able to have a source of truth that we can all standardize and use. And if UK Healthcare is saying this is what we see, and Vivian can look at that from a Kentucky State perspective or lens and say we're all looking at apples and oranges in the same way. So.
Well, good words to end on. Thank you all very much. The co-chairs of the commission, do you care to leave us with any parting words?
I'll just, Ms. Akins, you want to say something?
No, you go ahead and close us out.
Okay, just in closing, of course, today, Congressman John Lewis was funeralized, and I'm sure some of you, no doubt, read the op-ed piece that he requested to be published on the day of his funeral. Together, you can redeem the soul of the nation. And in that op-ed piece, he talked about how each of us have this moral obligation, to speak up, to stand up, to speak out, to do something when we know that we can do something to make everybody's life better. So when I think about health disparities, we have a moral obligation to make sure that people live a better and healthier life. And I hope that I hope we can do that. In fact, I believe we can do that.
Yeah. Well, thank you, Rosalind Akins and Dr. Gerald Smith, for your leadership, and thank you, our vice chairs of this subcommittee and the team members on this particular subcommittee. And in the words of Congressman John Lewis, who we honor today, and hopefully the work that goes ahead will honor him, keep stirring up good trouble, okay? God bless all of you, right? That's
Thank
what we're all trying
you.
to do, stir up some good trouble. We want to remind you that Tuesday, August 4th will be a conversation about housing and gentrification and law enforcement. We're probably going to need more than 90 minutes for that one, but we do hope that you'll join us for that. Send your questions in at townhall@lexingtonky.gov and stir up your own source of good trouble as well. In the meantime, wear your mask, stay safe, God bless, and we'll see you next Tuesday night.
Thank you, Renee.
Thank you.
Thank you.